So at Oxford Health, I would like to start with a brief background about services within Oxford Health. So Oxford Health provide 4 main services: mental health, community health, urgent care, and talking therapies, or used to be psychological therapy. Those 4 systems, they are supported by 2 strategic clinical systems, which is the ePMA and pharmacy. A long time ago, executives within Oxford Health tried to find one clinical system that can give the capability for delivering direct patient care for all those services. As you can imagine, it is an impossible task. So what they have decided to do is to follow what we call a best of breed strategy. Look for every service and see in the market what is the best clinical system that meet all the requirements by the service, and end up with this clinical system: RIO for mental health, EMIS for community health, Adaster for urgent care, PCMIS for talking therapies, and BetaMed for ePMA, and Ascribe for the pharmacy system. So, but the problem with that settings or configuration, that these systems never been developed in a way they are ready to exchange clinical information. For example, clinician using RIO will be accessing data within RIO, and if they want to access information for any other systems, they have to do like a manual login and accessing the systems silos. So that put the need for integration engine as a must-have capability, not as a luxury capability. That's how we ended up with Innovacom, and it enabled us to do that task. So after we've implemented Innovacom, through the years, we managed to do a lot in terms of the integration, getting data from various sources in different format, in different frequencies, and do a lot of transformation and sending the data to local, regional, and national target system in different format, different capability, different messaging type. And that is what we are looking after at the moment. I would like to take one case scenario, or the first case scenario is the integration between our mental health system and our ePMA and pharmacy systems, because in some cases for mental health, for example, when a patient go through a mental health relapse or mental health crisis, there is a need for an immediate emergency admission, followed by prescription, dispensing medication, and administer the medication in a very quick fashion. This is exactly how we managed to achieve that quick real-time integration between all those systems. So before the integration, like 2018, for example, our mental health system is not jointed with the pharmacy system. What our pharmacists used to do, look at 2 different screens and look for any activities in the main clinical system, like a new patient created, or admission, or discharge, or transfer from one to another, to manually go and make the update in the pharmacy system. Since the integration, that manual completely changed. The other scenario is True Colors. True Colors is a system that is being developed jointly between us and Oxford Health, but currently being enhanced further by Oxford Health and owned by Oxford Health. That is a tool provided for carers and patients to fill in questionnaire to self-manage their mental health state. This questionnaire then automatically generate various scores and then feed back through the integration engine and update the patient record within the clinical system, which is currently RIO. That help our clinician to monitor various aspects of the patient mood in various ways, like the depression, anxiety, sleeping pattern, the sleeping or the mood. That become like a full circle from creating a patient, send the information into True Colors, patient or carers filling questionnaires, and automatically get that information back to the clinical system, as well as dashboard in our Trust Operational Business Intelligence tool, which we call it TOBI, for service managers to monitor the service from the qualitative point of view. So, given the success that rolling out initially the children instance of True Colors, followed by a success deployment of our adult instance, then we are now taking that further to the next phase. So what we are doing currently, we are developing an integration to get the information from a new clinical system, which is EMS, from the community settings, care settings, into True Colors, because we've got few services that you're using EMS. They would like to use the capability or the questionnaire provided in True Colors and follow the same step that we've managed successfully to implement using the RIO or mental health system. The other new feature that we are developing currently, we are building a predictive model. For example, we took one questionnaire, the BOP-NDQ, in order for us to see what is the next step based on the questionnaire and the outcome or the scores come from that questionnaire. What is the next recommended next step for clinician? For example, if this patient requires, the next step, is it just follow the standard assessment or enhanced assessment, or no, they really need a complex assessment, and that feedback to the patient record in RIO. That is we've managed now to finish the testing, but now we are looking for ways, what is the best way to get that within or visualize in clinical system, and where we are engaging with clinicians who are the customers of this output from the predictive model. So currently we are having developed the infrastructure to support the integration from a simple one development environment with one integration engine to a properly set up infrastructure that support the 3 tiers of the development, from development to pre-production or UAT and the live systems. And in here in the green, that we've got a wealth of local, regional, and national data set fit to our integration in various instances, and split the data back into local, regional, national data or target systems. So the benefit through various projects, what we have achieved in terms of the building the integration capability, better patient outcome. That is achieved because we no longer, for example, do a dual data entry manually when we look for one system to another. Now the integration of the data become automatic, and then these data become available to the clinician in a way they've never managed to see it. We also getting data from one system to another, like the integration between our ePMA and RIO. Our clinician, they can see more information within RIO system, fetch from, for example, from ePMA within the same user interface, so that they can make a better decision, because there are more and more information presented to the clinician to make a better clinical outcome, which will ultimately reflect in improved patient care. We have also improved clinician efficiency, first removing the manual data entry I've mentioned for Ascribe, but also in particular project we did the integration with Docman, which is a system that used widely for trust to send letters or correspondence to GP practices nationally. So previously, before the integration, our clinician, for example, discharge letter from mental health, discharge letter, our clinician, after they generate the discharge letter, they used to go manually log into the system, upload the document, and wait for the status of the upload success, and then check later to see if that letter rejected or accepted by the GP practice, and then action upon that. If they reject it, see what the rejection is about, and then action. So that, with the integration in place, that process fully automated, and we estimated that manual process take 4 minutes per discharge letter or per document upload to do to Docman and send to GP. That resulted in more time now saved in terms of removing manual need for the data upload. As you can see, this automated integration led into time savings, and this time savings, now we did 2 papers in 2019 as soon after we proved the concept for the benefit of the integration, that how many minutes for those two actually save within each services, and that might make a huge difference for delivering the service. Cost savings. This is reflected in the way become less reliant on bank staff or contractors, because for pharmacy, I'm keep coming back to the pharmacy integration, because we used to have pharmacists come to do various jobs, because there is a lot of time that dual entry of the data that has been revoked or removed. Then that gave the staff more time to do things that we used to rely on bank staff or contractors to come and fill that gap for us, so become less reliant on contractors. Last but definitely not least is data quality. So now we managed to see information, like for example, take the patient demographics. When we get patient demographic data in the same platform from mental health system and from community health system, we compare and we say if it's some differences, then straight away we report that to our privacy officer for patient registration differences to resolve. So that resulted in improving the patient care. Also, one of the key benefits from doing that is we managed to generate a report that identify possible patient duplicated registration, which we do know that has a huge clinical safety aspect to it, because the clinical information will be split into more than one patient registration. That become like a product that usually, or a report that usually reviewed by the services to monitor. So I'm sure most of the integration that implemented elsewhere, they have achieved the same benefit in one form or another. So given the success that we have done so far and finishing some few projects, we do have a few projects that coming up ahead in the next financial year. The success of sending data from our pool of clinical system to regional shared care record, which is the Thames Valley and Surrey shared care record. Now we are expanding the data that we share with the shared care record for a wider benefit for direct patient care. For example, data from urgent care. Currently, we do have Buckinghamshire talking therapists in TVS. Next financial year, that will be followed by the Oxfordshire talking therapists and additional point of care devices information that we're working currently on in the integration. Also, given the success of rolling out or the integration between RIU, pharmacy, and ePMA, we would like to achieve the same success story using our clinical, our community health clinical system using EMIS. So that will close the loop that between a new patient added, a new admission created, that automatically will be seen between EMIS, Ascribe, and the ePMA. Medical devices, now we do have wide range of devices used in various systems like iStat, Athenian, ECG. These now we want to standardize all the results coming back from these devices in one platform, so that we will make these available in a consolidated way for end user to see all the results consolidated in one view. And the last integration plan for next year is the integration with the national referral system, or ERS, called ERS. Currently, our clinician manually logging into the system, then action login, accept the referral, reject it, or ask for new information. And if it's been accepted, then that result in a new record manual be created in our clinical system and a new referral created. So now we want to take that manual creation of patients and referrals by that automated process as soon as that's been actioned by the end user in the ERS system.